When people hear the phrase tumors of unknown primary, they often think it's obvious from the name what that means. I don't need to learn about that. But in fact, it's a really complex topic with some interesting aspects of staging that might be non-intuitive. So let's define an unknown primary. It's a malignancy, usually squamous cell carcinoma in the head and neck, that is discovered in a lymph node. Now we know that squamous cell carcinoma does not arise de novo in a lymph node, so it must have come from somewhere else. So we're going to look for a mucosal lesion. But what if we can't find a mucosal lesion to be responsible for this metastasis? I should note that every once in a while, it's not a lymph node metastasis, it's a distant or soft tissue metastasis, but it's almost always a lymph node. So the next question is, how hard have you looked for that primary? And these are the ways we look. We can do a complete physical examination. We can do a pan-endoscopy of all mucosal surfaces. We can do a contrast-enhanced CT or an equivalent in MRI. And we could do blind biopsies of likely primary sites. Most people referred here to the tongue base within the oropharynx as the most likely site to do blind biopsies. So how much workup is necessary to declare it to be an unknown primary tumor? Well, it depends on who you ask. Most people would say you at least need to do the physical exam, the pan-endoscopy, and the imaging. And some people would say you should also do the blind biopsies before you declare something to be an unknown primary tumor. While we're working this up, we use a slightly different term, undiscovered primary. This is when you have a lymph node with squamous cell carcinoma and you're somewhere in the process of doing these, but you haven't done all of the necessary tasks to declare something to be an unknown primary tumor. This may seem like an arbitrary distinction between undiscovered and unknown primary, but it's important for staging that we get through all of these things before we call it an unknown primary tumor. Carcinoma of unknown primary is an uncommon event. Only 2 to 5% of squamous cell carcinoma becomes an unknown primary despite all the workups we talked about. Now you've already heard me use a couple different terms: carcinoma of unknown primary tumor, tumor of unknown primary. There's a couple others worth knowing: occult primary tumor, and if you're staging, sometimes it'll be called the T0 tumor. All the same thing. So why do we get unknown primary tumors? Well, it may be that the primary is just too small for us to find. If it's less than half a centimeter, it can be very difficult to discover. Even if you do a complete tonsillectomy and sections, that may escape pathologic identification. Sometimes a tumor is embedded in a place where it's hard to find, like if it's deep in a crypt of a tonsil, it may not be evident clinically. Sometimes it came from a different source, like a cutaneous primary. Now that usually looks different to us histopathologically, but it's a potential area of confusion. Maybe it came from somewhere outside the head and neck. Maybe you're seeing a squamous cell carcinoma that came up from the lung, for example. And then there's the problem of radiologic hiding places, places where we need to be very careful to find these unknown primaries. So how important is it to identify an unknown primary tumor? Well, obviously you can't perform a surgical resection of the primary tumor if you don't know where it is, and you can't perform focused radiation if you wanted to treat it in that way. So what do we do? Well, unfortunately, the treatment of an unknown primary has very high morbidity. We end up radiating the entire mucosal surfaces that might have given rise to this tumor. You can imagine the degree of xerostomia that this creates. So these patients end up with severe morbidity. But on the other hand, there is a mortality benefit. These patients are less likely to die of their disease than patients who have discovered small primary tumors. Now, this is not because we didn't see it, obviously, but statistically, it works out that these tiny primary tumors or undiscovered primary tumors are less deadly. So what are the radiologic hiding places, the place where we need to really look carefully so as not to overlook these on imaging? Well, one is the nasopharynx, another is the tongue base, by which I also mean the lingual tonsil, and the third is the palatine tonsils. These oropharyngeal locations are the most common locations to give rise to undiscovered primary tumors. So what radiologic clues are we looking for? In the nasopharynx, we really need to inspect the fossa of Rosenmuller carefully because it's a common location for nasopharyngeal carcinoma to arise. We want to look for retropharyngeal lymph nodes, which are closely associated with primary tumors in the nasopharynx. We want to look for otitis media or mastoid effusions, which are secondary findings that might suggest a tumor obstructing the eustachian tube. Remember, sometimes small tumors can have big mets, so even when you see a large nodal mass, you're still looking for a tiny tumor. So let's talk about the fossa of Rosenmuller. This little bump in the nasopharynx, this is the torus tubarius, and the eustachian tube is emerging right here. This is a cartilaginous prop that keeps open the eustachian tube. Behind this is a mucosal fold. The mucosal is coming down this side of the torus tubarius, turning around deep in the fossa and coming back over the posterior wall of the nasopharynx. That redundant mucosa back there, that pocket, is called the fossa of Rosenmuller, and it is the most common location for nasopharyngeal carcinomas to arise, so it needs to be particularly evaluated. This is what it looks like when you have a nasopharyngeal carcinoma arising in the fossa of Rosenmuller. Look at these nice preserved fat planes here on the normal side and how they're obliterated on this side. Also look at the effect on the bone. You can see it here, but it's clearer on the bone window. You can see the bone erosions along the anterior clivus. Nasopharyngeal carcinoma frequently extends back to erode the anterior aspect of the clivus. Here's an example of large retropharyngeal lymph nodes in the classic location, but you shouldn't just be looking for huge lymph nodes like this. You should also be looking for small retropharyngeal lymph nodes, like this example. When you see an unexplained mastoid effusion, like here, always draw your attention to the nasopharynx so that you can pick up primary tumors like this one. What about the tongue base? Well, these patients often have changes in voice and bilateral lymphadenopathy because of the rich lymphatic supply to the tongue base. But you have to be careful because there is normal asymmetry on CT and physiologic asymmetry on PET that may mimic a tongue-based tumor. Here's an example of a tumor in the palatine tonsil, and you can see it extending down into the tongue base and filling the vallecula. So what about the palatine tonsils? Well, I don't have any good clues for you here. Sometimes these give rise to more cystic metastases, but that's true of the lingual tonsil as well. Many people will advocate for a preemptive tonsillectomy in patients with an unknown primary just to catch these. Here's an example of an asymmetry of the palatine tonsil, and you can see versus the other side. But again, you have to be very careful in this location because patients with unilateral tonsillectomies will have a very similar appearance after they've recovered from their surgeries. Another important concept is that of drainage patterns. That is, once you find an abnormal lymph node, how do you work your way back and figure out where that primary tumor might have come from? This is the familiar diagram of the surgical levels in the neck, where level 1 is under the jaw, 2, 3, and 4 are most of the internal jugular chain, 5 is the posterior triangle, and 6 is the previsceral Delphian nodes. So a familiar diagram, I hope. Tumors that arise in the nasopharynx often go to retropharyngeal nodes, but they may just instead go to level 2. It's about 50-50 which of these they'll go to first. After treatment, the nasopharyngeal lymphatics can redirect and involve level 1 or occipital lymph nodes. The palatine tonsils in the anterior half of the tonsil, usually to levels 1, 2, and 3, and in the posterior half, almost always to level 2. But if you actually get into the posterior pharyngeal wall, then level 5 and retropharyngeal nodes may be involved. Here's that example of the palatine tumor again. Tumors of the soft palate will most commonly go to level 2, and if you haven't guessed, level 2 is kind of a theme in all of these. But sometimes a soft palate tumor will go to level 3 or even retropharyngeal nodes. Tumors that arise in the tongue base are famous for having bilateral nodes because of the rich lymphatic supply of the tongue base that has crossover lymphatics. Even a unilateral tumor of the tongue base will sometimes end up with bilateral nodal disease. It can go to levels 2, 3, and 4, sometimes 1 and 5, so it's really all over the map. Often, tumors that arise in the tongue base will give rise to nodal disease that is clinically negative, but radiologically positive. Tumors that arise in the larynx will most commonly go to level 3, but levels 2 and 4 may also be involved. There's an important concept of downstream metastases versus upstream metastases. Usually, once a lymph node is involved, future lymph nodes are involved downstream, that is, more inferiorly down the neck. It is possible for nodal disease to travel back up to higher nodes, but usually it is the most superior node that defines the primary drainage and allows you to work your way back to the site of the primary tumor. Here's an example of some upstream metastases where parotid lymph nodes were involved from a tumor that actually arose within the larynx. So what about PET-CT? Can that help us in the setting of an unknown primary tumor? Well, it turns out that 25% of unknown primary tumors become known if you do a PET-CT. And when I say these, I'm talking about true unknown primary tumors, patients who have undergone the pan endoscopy, the physical examination, and the imaging. If you then do PET-CT, you'll find another 25%. Now, PET-CT also is useful in staging, so these patients might be undergoing PET-CT anyway because of their nodal disease. Here's an example where I think it's really hard to find a primary tumor. This is a patient with an unknown primary, but the tumor is on this image. The PET-CT makes it a lot easier to figure out where that primary tumor is there in the base of tongue. Here's another example. You can see the cystic lymph node. There's a primary tumor somewhere on this picture. PET-CT to the rescue. It's another tongue-based tumor. It's there. It's just, you'd never make that call on CT alone. Here's an example of a submandibular lymph node on PET. And the actual primary tumor turns out to be cutaneous up here along the temple. Here's an example of a solid metastasis here in level 2. We're behind the submandibular gland, so this counts as level 2. And there's the primary hiding within that lingual tonsil in the vallecula. All right, can you find the primary tumor on this case? I'm showing examples of the base of tongue because that is such a common site. That's why we do blind biopsies there. But if the lesion is off lateral in the glossotonsillar sulcus, for example, that might be very hard for blind biopsies to get because we don't go all the way that far out laterally. And we can talk about robotic stripping of the tongue base if you'd like, but even that might miss such a lateral tumor. Here's another example where it's very hard to find the primary tumor, and you can blame the streak artifact for that, but it's still a problem for us. There it is, hiding in the streak artifact in the palatine tonsil. Now let's turn our attention to nodal staging of unknown primaries. How do you stage something if you don't even know where the primary is? Well, in the 7th edition of the AJCC, we said that the T stage was equal to 0, that's an unknown primary, and the N stage is the same for all primary tumors, so the staging was straightforward. It didn't matter. You were using the same N stage all the time. But in the 8th edition, it's different. Nodal staging is different for different primary tumors. The nasopharynx, the nodes are staged differently from the hypopharynx. HPV positive is staged differently from HPV negative. So which of the staging systems should we use for an unknown primary tumor? So here's the solution. The nodal staging system is based on the viral status of the tumor, and you can figure out the viral status based on the nodal biopsy. So HPV-associated cancers are assumed to have arisen from the oropharynx, that is the palatine tonsil or lingual tonsil. EBV-positive cancers are assumed to have arisen from the nasopharynx. So taking this a step further, if the tumor in the lymph node is HPV positive, then you use the HPV positive oropharyngeal nodal system, where N1 is unilateral nodes, N2 is bilateral nodes, and N3 is a node over 6 centimeters. If the tumor is EBV positive, then we use the nasopharyngeal staging system for nodes. N1 is unilateral nodes, N2 is bilateral nodes, and N3 is greater than 6 centimeter or below the inferior margin of the cricoid. If the tumor is HPV negative and EBV negative, then we're going to use the HPV negative nodal system, where N1 is a single node, N2A is greater than 3 centimeters, N2B multiple ipsilateral, N2C bilateral, 3A greater than 6 centimeters, and 3B definitive evidence of extranodal extension on pathology. Let me show you an example. Here we have a solitary node. This is the only evidence of nodal disease here. It's greater than 3 centimeters. So is that an N2A node? Wait. We don't know what the HPV status is. Turns out it's HPV positive. So that 3 centimeters doesn't matter anymore because we're just worried about a unilateral bilateral. This is N1 disease because it's unilateral disease. Here's another example. Now we've got a lot of lymphadenopathy down in the base of the neck. There's no single node that's greater than 6 centimeters. Okay. So would you call this an N2 or maybe N2C? Wait, we don't know the EBV status. When I tell you that this disease is EBV positive, that changes everything. We know that there are nodes below the level of the cricoid, so this is N3 disease. Here's another example. This is the only lymph node, this one here. It's the only one. It is greater than 3 centimeters, but this is HPV negative and EBV negative. So should we call that N2A? Well, wait, there's one more thing. What about extranodal extension? Now, we know that we cannot use radiologic findings to substitute for pathologic findings, at least in AJCC 8. That's likely to change in AJCC 9. But for now, we have to use pathologic. But there's so much evidence of extranodal extension here. Look at all this infiltration. I guarantee you this one is going to be positive for extranodal extension. And when it comes back positive, this is going to be N3B. Now, there is an exception to extranodal extension. If you are HPV negative and EBV negative and you have a solitary node of less than 3 centimeters and you are extranodal extension positive, that's only an N2A. That's not N3B. If you really want to give staging, be aware of that exception for extranodal extension. Okay, once again, it's the only lymph node, this one right here. It's less than 3 centimeters. It's HPV negative and EBV negative. But the extranodal extension is positive. Look at that relationship to the sternocleidomastoid. Look at it invading the paraspinal musculature. Of course, it's E&E positive. So are we going to call this N3B because of that extranodal extension? Well, this is the exception we were just talking about. This is a node of less than 3 centimeters, and thus this is only N2A despite that extranodal extension. So staging of an unknown primary is more complex in AJCC 8th edition. Because there are different schemas for different viruses. What we do is we presume the most likely site of primary based on the viral status of the tumor. And as I alluded to, once we get to AJCC 9th edition, which should be coming out in 2025 or maybe 2026, you can expect more emphasis on extranodal extension and on imaging findings of extranodal extension, not just pathologic findings. So what do you do if you don't know the viral status? Because sometimes you don't get that history as you create your report. Well, the same radiologic findings are important regardless. The size of the largest node with cutoffs of 3 centimeters and 6 centimeters, multiplicity on one side of the neck, bilaterality, the site, using those surgical levels of 1 through 6, and the sites of additional like retropharyngeal nodes. Don't forget to mention if there is definitive evidence of extranodal extension on imaging, and if there are nodes that extend below the inferior margin of the cricoid, those may factor in. But if you list all of these things, you don't even need to know the viral status. You'll be giving the oncologists and the surgeons, and hopefully yourself when you go to the multidisciplinary conference, everything that is needed in order to stage the tumor with the viral status once it's known. In summary, it's really important to identify a primary tumor if we can. Identifying the primary improves the outcome for the patient, and it reduces the morbidity because we can focus our treatment on one area of mucosa instead of trying to treat all of the mucosa. It's important for a radiologist to know where tumors tend to hide from endoscopy, and also know how tumors tend to drain based on the site of the primary tumor, so that you can work your way back logically. When you see a pattern of spread to nodes, know where that pattern was likely to have derived from, where the primary tumor is most likely to be. PET-CT really should be considered the standard of care for patients with unknown primary tumors in the head and neck, because not only will it show the pattern of potential distant disease and help stage the tumor that way, but it has a high likelihood of identifying the primary tumor itself.